injury lecture on your own. And then if we power through today, maybe just go like 10 minutes-ish over time. I don't even know if that will need it, but I'll try to power through, but I don't want to go too fast because this is a very important lecture, the airway one. But I want to make sure you guys understand the concepts, and we'll also reinforce these concepts during the EMED lab. Now the EMED lab dates have been changing. I think they're going to change again. Instead of it being 2 half days, Monday, Tuesday, I think it's going to be a full day Tuesday, but it's a full day for us, only a half day for y'all. So you guys will be split into morning, afternoon groups. So we'll talk more about that as they keep adjusting the schedule, but I'll keep you guys apprised of it. Anyway, so let's go on. Everybody okay? You got a brain dump after that women's health exam? That's pretty rough, right? Yeah, it's a pretty tough one. I was the reviewer for that exam, and even I was stumbling over some of those questions after I've already seen the material. So not my area of expertise, thank goodness. Okay, anyway, we're going to pick up with cauda equina. So this is where I left off last time. I want to make sure you guys know that cauda equina is rarely diagnosed immediately after trauma. Who presents with cauda equina? I'm sorry? Usually people who've had chronic back pain or previous back surgery, they come in with relentless pain, and I want you guys to remember that one of the first things that they present with is actually urinary retention. Everybody thinks of incontinence of urine or bowel, they think about saddle anesthesia, but long before that happens, they get urinary retention. So anytime I see a patient that has severe low back pain, presenting to the emergency department, like an acute exacerbation of chronic low back pain, the first thing I'm doing is I'm having that patient urinate if they're able to. If it's a male patient, give a little bedside urinal, and then I do what's called a PVR. I'm getting that ultrasound and I'm looking at their bladder, and there's actually some measurements where you can measure the bladder in 3 planes, and it will calculate how much volume of urine is left in the bladder. And by definition, depending on who you read, there should be at least less than 100 cc's left in the bladder. If there's more than that, then they have cauda equina or urinary retention, and in the face of low back pain, you have to assume that's cauda equina. Have you all heard that before? About urinary retention being the first symptom? I've seen some bad cauda equina, and some of the urinary retention is sometimes missed. So do yourselves a favor, always do a PVR, a post-void residual, on every patient that comes in with really relentless back pain. If they just had like, oh, I have a little muscle spasm, all that, not a big deal. But they can have decreased rectal tone, they can have sciatica, things like that. There's rarely do we do MRIs in the emergency department. There's only 2 indications that we do. One is cauda equina, the other is when we think somebody has a stroke. We'll do a CT angio of the head and neck first, and then we'll probably admit them for MRI, MRA. Those are the only 2 times we do MRIs in the emergency department. Why don't we do more MRIs in the ER? Very time consuming. Even with the new machines that are only like 20 or 30 minutes, it's still time consuming. It's just ridiculous. So if we think somebody needs one, we'll admit them, they'll get the MRI on the ward, and we'll facilitate that. Sometimes though, they'll make us do the MRI of the low back if we think there's cauda equina before we actually disposition the patient, because they need to know, do they need neurosurgery, do they need, just medical management, that kind of thing. But here are some symptoms. Again, it's not a true spinal cord syndrome. It's usually acute exacerbation of chronic low back pain. All right, so we talked about this 2 weeks ago. Okay, so first of all, I haven't seen you guys forever. I missed you. I mean that sincerely. Because I wasn't on the schedule all week, I took my family to Cabo, Mexico. And as I was looking out at the ocean, I was thinking about y'all and how knee-deep in misery you probably still were. And I felt a little guilty for just a fleeting moment, but it was an all-inclusive. So I got over it pretty quickly, okay? But anyway, I have genuinely missed y'all. So we talked briefly, if you remember, from a few weeks ago about neurogenic shock. It's a true shock. It's a distributive shock, right? How do they present? Hypotense, bradycardia, they're warm, vasodilated, red, flushed. And so we know pretty early if somebody has a high C-spine injury and they're presenting with neurogenic shock, that is not from hemorrhagic shock or hypovolemia. But assume all trauma patients that are hypotense initially to be hypovolemic due to hemorrhage until proven otherwise. And once you prove otherwise, with this neurogenic shock, folks, you might have to actually give them pressors, all right? So anyway, remember, they're warm and dilated, so it's completely different, and they have relative bradycardia because, again, all of their, the sympathetic nervous system has been taken out, so they don't get tachycardia and all that compensatory stuff that we get. all right? So just remember that, but also remember, all trauma patients are assumed to be hypovolemic from hemorrhagic shock if they're hypotensive until proven otherwise. I know I said it over and over. So again, we talked about spinal shock, if you remember. It's not a true shock. We should call this spinal stunning. I wish I could rename it. It's not a true shock. This is where somebody has an insult, let's say it's at T7, all right, and there's no reflexes below that at all. At a minimum, even if somebody has a complete lesion, they should have a bulbocavernosa reflex or a plantar reflex. No matter what, even if it's a complete lesion, complete dissection of the cord, they should have those reflexes. Those are very fundamental brainstem type reflexes. So if they've lost those reflexes, there's some degree of spinal stunning happening, meaning that you cannot get a good, accurate neuro exam until that spinal stunning has worn off. And then once it's worn off, you can do a more accurate neurological exam to see the degree of injury that that patient has. So you're hopeful that they'll have some recovery. So how do you know when spinal shock or spinal stunning has worn off? Yeah, they did a return of the bulbocavernosa reflex or the plantar reflex, okay? So that's why that's important. That's something you should always carry in your mind and going forward. Okay, they'll have delayed plantar and bulbocavernosus reflexes. They're the first to return, and that's why when you're on a neuro ICU, if you're working in that capacity or you're a surgery PA, you may actually be doing those reflexes and stuff. That's not something we typically do in the ER. We'll do a quick neuro exam and get them dispositioned if they came in as a trauma. Okay, so how do we diagnose spinal injuries in the ER under like acute traumas? This whole block is trauma. How do we diagnose spinal injuries? We do a bunch of plain films on these folks. When they come in and they just had a rollover accident, you know, anybody hear about that accident in Austin?
Yeah.
Last Thursday? It's awful. Yeah, semi-truck, they were speculating it was a subcontracted Amazon driver in a white truck, just hit a bunch of traffic and just barreled through and hit 17 cars, basically. Killed 5 people. He's being charged with intoxicated manslaughter, and then he's also being charged with other things. Anyhow, a little child was killed, a baby was killed, and 3 adults. It was really awful. And then like 5 or 6 other people were airlifted to some of the surrounding hospitals. So pretty terrible. So any of those hospitals that received any of those patients, how are they going to diagnose their injuries? Acutely. How do we do it? So in a trauma bay, remember when we do the whole primary survey, X, A, B, C, D, E, F, G, which is go to CT scan if they're stable. So acutely we'll do a quick AP chest and pelvis, but then if they're stable, we diagnose these injuries via CT scan, all right? And so what we're doing is that trauma 6-pack we talked about, a non-con head with contrast, face, neck, chest, abdomen, pelvis, and the reason why we do the rest of it with contrast is because we're looking for vascular injuries like carotid or an aorta tear, that kind of thing. We need to see that extravasation of blood, of contrast coming out, and that's how we know there's a vascular injury. So that's why we do it. But what they do is they reconstruct those images. They don't have to re-CT them, but they reconstruct the images and they're able to see the cervical, thoracic, and lumbar spine. So initially, we do a quick AP chest, AP pelvis. We're just looking for massive injuries to the chest and pelvis, and then if they're stable or we stabilize them, then we'll send them to CT, and that's how they're typically diagnosed, which is why we miss injuries sometimes, because we have to take them to surgery because they're not stable. They can't ever go to CT, but eventually the imaging modality of choice is a CT scan, okay? All right, the nexus criteria, did y'all learn this before in either ortho or any other capacity? So this is the National X-ray Utilization Study. It's the criteria that you will employ for the rest of your careers on whether you should image somebody with a neck injury. So who here has been in a fender bender? A little accident, right? Anybody have neck discomfort? Maybe you got your big head's got tousled around. I mean, I got a big head proportionally to the rest of my neck. It gets tousled around. I have a little neck pain, a little lateral neck pain. Do I need to be imaged? Well, you don't know, right? There's criteria that helps us. So the nexus criteria is a multi-center study and is now the standard of practice. And basically you can employ these items, there's 5 total, but if they don't have any of those things, you don't have to image them. But if they have even one, you have to CT them. So those are midline cervical tenderness, so on the bone, tender, bad. If they just have lateral, like torticollis or some cervical muscle strain or paraspinal muscle strain, not a big deal. But if it's midline, they need to be imaged, and this is just of the neck, okay, C-spine. Okay, there is no criteria for thoracic or lumbar spine, this is just C-spine. Anyway, they have to be alert and not altered, all right? They can't be intoxicated. They cannot have a focal neurological deficit, and they can't have a distracting injury, all right? Does that make sense? So as long as they don't have any of those things, then you don't have to image them. But if they have any of those things, you have to do a CT of the neck. The other criteria is that's not part of Nexus is that if you're age 65 or older and you have trauma above the clavicles, you get a head and neck CT. I would remember that, okay? 65 or older, trauma above the clavicles, you need a head and neck CT, all right? So what's a distracting injury? Yeah, maybe a huge femur fracture with a big hematoma, that's distracting. I'm probably going to be a little more preoccupied with my giant femur injury than my neck when you're feeling on my neck. So that's a distracting injury. What if somebody has a little broken toe like I do right now from having such a great time in Mexico? And is that a distracting injury? I mean, for some people it's pretty ridiculous. So there is some subjectivity to this, right? So the reality is most of the time it's a major injury, all right? It's not something small like a broken toe, all right? All right. Okay, Nexus, that's how we do it. It's a national X-ray utilization study. Again, it determines who needs a neck CT, who doesn't. Now, I'm not talking about your multi-system blunt trauma like the folks in Austin last week. We all know they needed 6 CT scans. We're talking about the person that comes in, they're in a fender bender the day before. Do I need to image them or not? And now you apply Nexus. And there's a P-card criteria for children, all right, for head and neck injuries. Okay, it's P-card for children, Nexus for adults. All right, so we do and used to do x-rays of the neck back in the day, and that was a long time ago before some of you were born. Now we do a CT scan, it's better, all right? We used to do AP lateral and a Waters view. Have you guys heard of that? Do they still teach that in x-ray? Yeah, it's ridiculous. A Waters view is where you have like an odontoid view, where you have the patient open their mouth, and they take a picture of them inside of their mouth. It's so stupid. And then they look at the odontoid. It's very hard to actually see, and a lot of injuries were being missed. So the CT is the gold standard for cervical spine injuries, all right? Okay, there are some advantages to plain radiography. We can do it at bedside at a trauma center. We can do bedside x-rays. So if they're too unstable for CT and they think they have a major C-spine injury, they might want to do some x-rays at the bedside because the patient's too unstable for CT, but otherwise CT is the gold standard. Okay, again, modality of choice. I've emphasized that pretty good. Are y'all okay? I hate that I have you post-test. Okay, I'm so sorry. I'm not at my best either. I might have told you I have a broken toe. Okay, okay, I'm just kidding. Okay, so can you have ligamental injuries of the C-spine and the bones be intact? Can we tear ligaments? Sure we can, very easily. And how do we know? Well, the CT is negative and they have persistent pain. So in those folks, we'll put them in a soft collar. We assume they have a ligamentous injury, and we say, hey, you need an MRI at some point, 7 to 14 days after the injury. We don't admit them for that, but sometimes if they have persistent pain or they have focal neurological deficits, we want to err on the side of caution, and we are going to arrange for them to have an MRI in some capacity. Okay, that's for ligamentous injury. Otherwise, we don't do MRIs, and we're not doing them in the ER. This is something that's outpatient, or you can refer them or back to their PCM. Okay, what about T and L spine imaging? Who gets thoracic and lumbar spine imaging? There's no criteria like Nexus for mid and low back, so how do you know who to image, who not to? Yeah, so midline pain, whether it's the neck, mid-back, or lumbar, if they're midline uncomfortable for some reason, they get imaged. If you're an old person and you fall flat on your bottom and they have like L4 tenderness, you should image those folks, all right? and especially if they have any kind of neurological deficits. Now, there's all this stupid insurance criteria. Anybody here believe in insurance fraud? Believe that it exists, right? It absolutely does. And so they'll deny claims, but they'll also make you do ridiculous things. They'll make you do x-rays and physical therapy for 4 weeks before they'll do an MRI of somebody that has clear neurological symptoms. And so a lot of times we're obligated just to do some plain films because they haven't had them, even though they haven't had trauma. So usually this is a personal decision that you make on how much you want to try to help facilitate the treatment for the patient. All right, but obviously it's indicated if they have neurological deficits, midline tenderness, severe pain, or they have a fracture in another area of the spine, you should probably image the entire spine because more than likely they'll have an additional fracture, okay? And that's what this says. About 20% of patients with a spine fracture in one segment will have a non-contiguous second fracture somewhere else. So old person falls down and goes boom, they have an L4, like injury, you should probably do their entire spine and chances are you're gonna find that they have another injury. Okay, so how do we treat these folks? Who do we send home with spinal injuries and who do we keep? Come on, you guys know this. You guys still thinking about mastitis? Oh, I'm not a psychologist. What's that? Sure. Exactly what you said too. You know, if there's not a lot of loss of disc height, it's something that can be treated. It's a stable fracture. Remember a few weeks ago we talked about stable versus unstable. So if it doesn't include 2 or more columns of the same level, they're stable, they can probably be treated as an outpatient. Otherwise, anybody with neurological deficits, unstable fracture, people like that, you maybe come in. Makes it kind of simple. Sometimes it gets a little confusing when they have compression fractures, like those older folks. A lot of times the surgeons don't want to do any kind of surgery on them anyhow. And so their criteria is if they have a compression fracture, as long as there's less than 50% reduction of height, as long as there's less than that, they can go home. If it's 50% or more, then they get admitted. Does that make sense? And sometimes we do social admissions. Sometimes little old lady lives by herself. She's got an L4, I keep saying L4 fracture, because that's what we see a lot. She's having a hard time getting around. Sometimes we'll just socially admit her for a day or two for pain control and just to help her out, feed her, and stuff like that. So sometimes you just have to make decisions that's in the best interest of your patient. Okay, we talked about chance fractures. When do we see chance fractures? I know it's 2 weeks ago. When do we see them? I'm going to remind you, it's seatbelt injuries. And we used to see them a lot worse before we had the airbags and the shoulder harness part of our seatbelt. But when it used to just be the lap belt back when I was a kid, when people would get a seatbelt sign and you see this giant bruising across the abdomen, and then you see a chance fracture of their lumbar spine, there's a chance that they have an intra-abdominal injury, like something severe. And so that's when we also see them. But this is what it looks like. It's a flexion distraction mechanism, so like they're really high, rear-ended at high speed. The body gets thrown forward against the belt, causes injury, and actually fractures the spine. Anyhow, it looks like a transverse lucency of the vertebral body, and then they have increased height of the posterior vertebral body. So this is a picture of it. I would remember this particular fracture. Okay, so what's a pathological fracture? Yeah, this older person, or it could be a younger person that has cancer, or maybe they're very osteoporotic or osteopenia, and it doesn't take much to have a fracture. So there wasn't a true trauma. It just they come in, they just all of a sudden have back pain. You do an exam, they have midline tenderness. You do imaging, even though there was no trauma mechanism, and they have a fracture. So that's a pathological fracture. I would definitely, if you see one, I would definitely CT them. What about sacral or coccyx fractures? What do you guys think about those? Depends on the degree, right? There's not much we can do for coccyx fractures. Did you guys all learn about that in ortho before, a coccyx fracture? It can be terribly debilitating for somebody if they fall right on their coccyx and it breaks or dislocates. A lot of times all we do is NSAIDs and the little donut pillow. You gotta sit on this stupid pillow and carry it around with you, and that's about all you can do for them for treatment. It takes a long time to heal. Sacral fractures that can involve the central canal can cause bladder and bowel dysfunction, very similar to a cauda equina, all right? Rarely do they have other neurological deficits, but they will have bowel issues and bladder, and they may have to self-cath if it's a complete lesion. So here's an example of a coccyx fracture. You guys see that? It's pretty, here's the coccyx, okay? So again, just donut, NSAIDs, you can take Tylenol, that kind of thing. Usually we don't even consult anybody, we don't call ortho and say, hey, we got this coccyx fracture, because what do orthopedic surgeons want to do? They're there for surgery, right? They're not there to follow up on something that's non-surgical. Again, the rubber donut pillow and some analgesics. For spinal injuries, we talked about this before, how do we treat them? It's very similar to brain injuries. What we do not do for either of those are steroids, high-dose steroids. That went out a couple of decades ago. We don't do steroids, it worsens brain injury, it worsens spinal cord injuries, we just don't do it. It does decrease inflammation, but it doesn't do anything for the neurological cascade that happens after the spinal cord or brain injury, so we don't do it. Okay, we talked about neurogenic shock again. If we know for sure it's neurogenic shock, we gotta get their pressure up, right? Because they have unopposed parasympathetic activity. We can try IV fluids first, as long as we know that there's no internal hemorrhage. Because if there is also an internal hemorrhage, what's the fluid of choice? Definitely blood, right? So if that doesn't work, the fluids, if you know there's no other injury, then you can go to pressors. What kind of pressor should you use? Pick one, okay? You can use epi, you can use any of them, that will be fine. Any kind of positive ionotrope would be fine. Okay. And then we talked about this is how we approach the critical patient in trauma. This is the same algorithm that we do for all trauma. Any questions about the spinal flexure? I know it was parsed, and I hate starting and stopping lectures. I'm usually better with time management, just the way it worked out. No questions at all? Okay, there are some questions from, the spinal. There's about 4 or 5 questions on your exam from the spinal lecture. I think they're pretty straightforward though. So, do you guys need a 5-minute break before we go into airway? Or drive on. All right, that's what I think. Let's drive on. This is more exciting, okay?